there are items so there are items that really looked good on paper in a lot of ways. Like, have you ever had a feeling that your thoughts were being directly interfered or controlled by another person, or your mind was being taken over by strange forces, right? So it sounds roughly like our understanding of what a delusion might be. But what these studies found was that somewhere around 7 to 10% of the population was saying yes to to these items. And we know that 7 to 10% of the population does not have a DSM diagnosis of schizophrenia, especially in a general population household sample. Yeah, and this number actually varies quite a bit across cultures, which seems to have something to do with, uh, for one, reporting culturally appropriate experiences in response to these items, like in many cultures, like feeling like you're speaking with deceased relatives. Um, and in some cultures where mental health may be more stigmatized, you find very, very low prevalences. So in World Health Organization data, this rate ranges from somewhere around 0.5% saying yes to these items up to about 50%, depending which country you're looking in. So there's a lot of issues with what do people mean when they say yes to these questions. But what tends to be consistent is that no matter where someone's drawing the line in their willingness to say yes to these items, it seems to share the correlates with schizophrenia in terms of both risk factors and clinical outcomes. So it seems like there's a lot of cross-cultural validity in terms of how significant of an experience someone has to have before they'll say yes to one of these items. But it seems also that wherever that line is drawn, it's still indicating something that's roughly phenomenologically similar, if that, hopefully that makes sense. Um, okay, so we have this problem where way too many people are saying yes. It's clearly not schizophrenia in all those cases, or even probably, depression with psychosis. Um, what does this mean? What does it mean when someone is saying yes to these questions? And one of the first things that I tried to look at with this, and this is when I was a doctoral student, was if these are really by definition kind of subclinical experiences, um, do they matter to the people that are experiencing them? So this is using data from the Collaborative Psychiatric Epidemiology Surveys, it's 3 data sets put together of uh, about 15,000 adults in the US. And one thing that I found was that if you look at rates of treatment seeking among this population, for one, psychotic experiences are an indicator that someone will be seeking psychiatric treatment. And if they're not seeking treatment, they're more likely to still perceive a need for care. And I think this one's particularly interesting, a larger effect for being encouraged by others to seek care. So whatever it means when someone says yes to these questions, it does seem to indicate some kind of clinical mental health need, and even a mental health need that seems to be particularly apparent to other people. And there's other studies. I didn't want to, I was trying to keep it relatively simple, but there's other studies linking this to functional effects. This wasn't the only one linking psychotic experiences to treatment seeking. So there's a good amount of data showing that whatever it means when they say yes, it seems to mean something to them that is either distressing or functionally impactful. Um, and so it became more common to use these as proxy measures for studying the epidemiology and really the etiology of psychosis. So you could relatively easily assess psychotic experiences and see what risk factors are connected to these self-reported symptoms. And that they're also clinically significant, although not really until recently has there been much attempted to build off that clinical significance and try to intervene. Let's see. Oh, sorry, didn't mean to. Now, this is another paper that was part of my dissertation, but I've done quite a few studies on this, and this is where we're going to loop back and think about interventions towards the end of the talk. Um, which is, one of the first things I found was that aside from being linked to help seeking in general, um, uh, self-reported psychotic experiences are very strong indicators of both suicidal ideation and suicide attempts. Now, this was uh, kind of the second time this was really shown. The first time was by Ian Kelleher in Ireland. Actually, no, I think the first one was at Sushi Nishida in Japan, and then Ian Kelleher in Ireland, and then this study in the US. And I think there were more than three papers, but there was really a few main studies that were presenting this association. So some degree of maybe not quite universal, but three-country replication across different age groups. The Ian Kelleher work was especially interesting because it was with really little kids around age 11 who all of them say yes to these items because they all kind of have unusual thoughts, but or about half of them say yes to these items, but even then it was still related to suicidal thinking, which is kind of hard to think about at age 11, but it is a thing that happens. Okay, so a big increased risk for suicide attempts related to these symptoms. It's about a five-fold difference. And in the younger age group, it declines a little bit as people age. But what was really interesting in this work and what made me and some other people doing this work really pay attention to this was that um, psychotic experiences seem to be especially strong indicators of suicide risk compared to the things that we often think clinically as the big risk factors, right? Alcohol use, anxiety disorders, depressive disorders, drug use. Um, and part of what seems to be, I don't know if special is the right word, unusual about psychotic experiences in their relationship with suicidal behavior is that they really seem to differentiate between those who think about suicide and those who make an attempt, which clinically is extremely hard to do. And in terms of research, we have very few established replicated risk factors that make that distinction. So we know that people who are drinking, who are using drugs, who are depressed are more likely to report suicidal ideation, but that in a lot of ways has limited clinical impact because we could also assess suicidal ideation by asking people. And a lot of times people will just self-report if they're having thoughts about suicide or not. What's really, really hard clinically is to then know how that will progress. Statistically, we have data that show we're, across all the helping professions, not very good at that. We could try our best, but in a lot of ways, based on current clinical knowledge, it's kind of out of our hands. We have a hard time really picking out who is most in need of intervention among those with ideation. And all these factors that we think of as the risk factors for suicide also aren't very good at that. So in suicide prevention, we call this the ideation to action pathway. David Klonsky really developed this idea that where we really need to focus our attention is what guides that transition from thinking about suicide to acting on it. And that's where we really need to intervene. And all the big risk factors actually do a poor job of predicting that progression. So depression's related to ideation. It doesn't really tell us who will act on that ideation. And same with most of the other big risk factors. So all that's to say that this second figure, we were quite interested to find that psychotic experiences do make that distinction, where if someone reports psychotic experiences, they're more likely specifically to make an attempt versus having just ideation without an attempt. This is another thing that was also replicated in Ireland and with kids. It has been found other times since then, which really gives promise that these simple self-report items, even if these individuals saying yes to them don't have schizophrenia, even if they never are going to develop schizophrenia, may have some clinical utility because it suggests that we could ask these relatively straightforward questions and maybe have some insight on where is this suicidal ideation going to go, and is this person in especially high need of intervention? um, work that really needs to be play out in clinical studies more than it has. So I also don't want to be, overstate those findings where we really need more data showing that we could actually use this clinically to reduce the suicide rate, but it is really promising. Um, so I'm going to talk a little bit more about this association, and then we'll come back to it as a focus of intervention. This is just data from a meta-analysis from 2019. There's a more recent one in the works now. But basically looking at the association between psychotic experiences and ideation and attempt, and just showing that this is really well replicated now. Actually, this meta-analysis was only looking at longitudinal studies. So having reporting psychotic experiences at time point 1, these studies use various different age groups, predicted ideation with an odds ratio of about 2.4 and attempts with an odds ratio of about 3.2 at follow-up. And this is another thing where the data get quite complicated because the opposite association has also been shown, and in some ways it's still kind of jumbled mess of a literature, but there is this well-replicated effect of psychotic experiences leading to suicidal behavior. And in some ways that makes sense, right? Because these are both transdiagnostic indicators of a lot of distress that likely occur in the context of trauma, stress, other social environmental factors. But in other ways, it's kind of counterintuitive, right? Because many of the people that say yes to these psychotic experiences items are probably not really that bothered by them. They're probably saying yes to, kind of mildly suspicious beliefs, or they're saying yes because they sometimes maybe think they're hearing their name when they're out in public, but they're not really. Some people might say yes to the hallucination items because they feel like they feel their phone ringing in their pocket, which is something everyone experiences sometimes. So our understanding is that these are relatively low, not terribly distressing experiences in themselves for most people, but they're still strongly linked with suicide risk. So then we have to ask why that is, because it seems unlikely that symptoms of this severity are themselves the cause of someone thinking about or attempting suicide. And so over here in this second figure, this is from the same meta-analysis. It didn't include, there's another review by Emily Heilscher in Australia that really gets quite deep into this question. But this is from the Kitty Yates meta-analysis, looking at why these things might be related. And there's a lot of reasons why they would be related that go beyond a direct pathway. And I think this is really quite interesting because it opens up the possibility that there's ways to intervene with this co-occurrence that don't necessarily involve a direct focus on psychosis itself. Let me see. So I see there's a question in the chat. Yeah, so let's see. So the question is, what does a person need to be aware that they had a psychotic episode? Since most of these data are based off self-report, I would say yes, but I also want to reiterate that a lot of what people are saying yes to when we use the term psychotic experience isn't at the severity of what we call a psychotic episode. So again, this basically just means that someone said yes to these questionnaire items and they self-identify as having unusual thoughts, unusual perceptions that to them, they think other people don't have. So yeah, for these data, I would say it requires some self-awareness of that. But we do know that there's, strong links between psychosis and suicide at the clinical diagnosable range where there's Not always necessarily awareness or acceptance that that's what the person experienced. All right. Okay, so what I want to focus on here and what's really been the target of our attempts to intervene with this connection are these psychosocial factors, things that tend to be, it's partly a bias as a social worker, and I imagine for a lot of the audience, you may share that bias, that this is really some of the factors that feel important, things around stress, social isolation, adverse experiences. So I'm going to shift away from suicide for a moment and talk more about the general epidemiological data linking some of these factors to psychotic experiences. But we're going to come back to this when we think about interventions and um, think about how do we actually use this elevated risk associated with psychotic experiences for suicidal behavior, for suicide prevention, if it's likely not a direct connection. So what that means is if this is just a risk indicator, how do we then intervene with this? But we know that they're at a much higher risk. How do we then intervene with this population? Okay, so let's keep that in mind as we work through some of the understanding of where these psychotic experiences are coming from in the first place and what some of the risk factors are. And in a lot of ways, we could generally boil down a lot of the psychosocial factors to stress. So we look at a lot of different things in social work practice, like different types of trauma exposure, neglect exposure, discrimination, homelessness. At the biological level, your brain probably doesn't know what these things are. Your brain knows if things feel normal and balanced, or if that balance is thrown off, what we'd call allostasis and why am I forgetting the word? Um, homeostasis. Yeah, so homeostasis, everything generally seems fine. Allostatic load really refers to all of these kind of different influences that make you feel like something is wrong and needs to be corrected, no matter what that is. So if we're thinking about what might be leading to some of these symptoms and experiences, we could probably boil it down to things that affect stress in some way. So one of my first things I tried to look at with the epidemiology of psychosis, of psychotic experiences, was stress sensitivity. And I did an earlier, smaller study, but then I teamed up with Ai Koyanagi, who does a lot of work with the World Health Organization data. Um, and by the way, and I would also put in a plug for working with someone in a vastly different time zone because she was in Spain, and it was incredibly efficient because I'd write part of a paper and send it to her, and then wake up, and then her part was magically done, and then and vice versa. So it's kind of nice to have a working relationship with someone who kind of just keeps it moving while you're asleep and none the wiser. But so we were able to get through quite a few studies relatively quickly, looking at these World Health Organization data. And the one I really want to focus on is this one linking stress sensitivity and psychotic experiences. Um, so this was kind of fun because you don't always get to work with data sets of 250,000 people, but that's what we had here because the World Health Organization does incredible work from 39 different countries. And we didn't have a great measure of stress, but we had a question or two questions that asked, how much is stress impacting your life? So a rough indicator of are people feeling sensitive to stress or not. Interestingly, these really simple measures, people are really, really good at estimating their stress levels. We know that they correlate very highly with cortisol levels. If you ask someone to say, how stressed are you from 0 to 100, it correlates really well with cortisol and is much easier than getting a saliva sample. So it tends to be a pretty reliable measure. And most theories of psychosis etiology, like the social defeat hypothesis, diathesis stress model, um, social deafferentation hypothesis in some ways, connect stress to psychosis in one way or another. Part of the difficulty there is that psychotic disorders are stressful, right? If you have a psychotic disorder, chances are, statistically, chances are you're unemployed. Chances are pretty high that you have limited social connections, um, quite high that of homelessness, substance use, etc., and facing stigma and discrimination. Um, so we know people with psychotic disorders are more stressed, but we don't necessarily know which one came first. Um, because psychotic experiences don't seem to be that stressful for most people in themselves, that lets us look at, by focusing on that as the outcome, we could look at whether stress is, possibly etiologically linked to psychosis. And we found that this was the case, that those that report increasing levels of stress sensitivity on a 1 to 9 scale are about 20% more likely to also report psychotic experiences for each point on that scale. And this is basically holds true even when you adjust for anxiety and depression. Now, a 1.2 odds ratio doesn't sound that big, but when you look at it across a scale that, I don't know why we scored it 2 to 10 instead of 1 to 9. I think that was kind of a mistake, but anyway, that's what we did. It was because we added up 2 1 to 5 items, so that some score ended up being 2 to 10, but we should have changed it. Anyway, you end up with this huge difference going from about 6% saying yes to these psychosis items at the lower end, going up to about 24% saying yes at the higher end of stress sensitivity. So not the best measures in the world, but the largest study connecting these things, and there's been other studies that get much more methodologically in depth with smaller samples, showing converging evidence that stress matters for psychosis risk. And we looked at how it varies or not across countries, and it's a consistent finding across every country in the study. These are all the countries included in the World Health Survey. We did see stronger effects in studies that were really experiencing a lot of upheaval at the time, like Bosnia, the Czech Republic, some of the post-Soviet countries. This was collected in I think the late 90s, but I might be off on that now. But really a consistent effect across everywhere. Even Vietnam's a country where almost no one says yes to the psychotic experiences items. I think the prevalence of yes responses was about 0.5%. But even there, we're seeing this connection, and it seems to be very consistent. So based on that, we could say globally, it seems that stress matters for psychosis in some way or another. I think pretty well accepted now, but it's, if you even go back about 20 years, there's a lot of people that did not believe this was relevant, that psychosis was purely a biological phenomenon and it didn't really matter what was happening in someone's life, which is kind of odd because then you have to imagine that all the high rates of trauma and childhood adversity are just a coincidence, but here we are. Okay, so then another question would be, what types of stress are most impactful? Are there things that matter more than others? People are stressed out a lot. Most of them don't have psychotic disorders. Most of them have anxiety or depression or nothing. So what makes a stress exposure different and perhaps more relevant for psychosis? And it seems to be things that are marginalizing and isolating. And a lot of this work was done, a lot of the early work on this was done in Northern Europe, where that often referred to SES or migration status. Of course, doing this in the US, we tend to think especially of ethno-racial discrimination. And so working with some colleagues, especially Deidre England at City College, Hanzo and Courtney Cogburn, who were at Columbia at the time, and Ellen Lukens, who is my PhD mentor, we did some studies looking at how discrimination in particular is linked to increased risk for psychotic experiences. Similarly, acculturative stress among migrants to the US I've done some work. I'm not going to get too much into the Tokyo work, but I've also done work in Tokyo where racial discrimination generally, um, there's very little racial heterogeneity. Um, Most people who live in Tokyo are ethnically Japanese. Um, so we couldn't really look, we actually tried to look at racial discrimination, and there were just too few people for the analysis. And even migration ended up being a little bit tough, but we had enough people that we could at least run a regression and found that migration likewise was associated with increased risk for psychotic experiences there in Tokyo. And in that other forms of marginalization in the US were likewise associated with psychotic experiences. So one we looked at was called neighborhood change, basically um, a self-report indicator of perceived gentrification. So roughly feeling like you're being pushed out of your neighborhood, and especially feeling like there's a conflict between your status within a neighborhood and that of the neighborhood itself. So something that we really see when, um, in New York, this is kind of the never-ending problem, where neighborhoods sometimes vastly change very quickly, and the groups that were there before could no longer afford, and many times can't afford to move because they're, perhaps living in public housing, but also can't afford really the day-to-day reality of their neighborhood, like the price of food, the price of any kind of like outside activities. Um, so that's a different type of marginalization that's not, while it's related to race and ethnicity in the US, is distinct. Likewise related to prevalence of psychotic experiences. And then we started to look more specifically into things that are especially more impactful forms of social stress, I guess you could say, or trauma. Um, Finding that gun violence, exposure to gun violence fatality, so like through a loved one or a friend, um, is also related in particular to increased risk of psychotic-like symptoms. I also want to clarify, I get in the habit of using this term psychotic experiences. That's the term that is widely used in the literature. I think it's too strong of a term. I think we should probably be saying something like, you know, uh, I don't know, anomalous experiences, or some people use the term aberrant salience. Um, I'm sticking with the widely accepted term, but um, I also don't want this overinterpreted to mean that if you have someone you care about die due to gun violence, that means you're going to develop psychosis. What it is that it's makes you more likely to experience perceptions and beliefs that may be more on that spectrum, but probably not at that severity level. Okay. Sorry. And let's see. So these are some new data where we try to take this a step further and look at, so I collected these data with Lisa Fadina, who's at University of Michigan. And we were looking at, trying to look at a wide variety of risk factors at once, really moving away from the model that was really prevalent or common in epidemiology for a while, of looking at one risk factor and one outcome, and trying to model them together to understand which ones are more relevant. And here we base this off of the social defeat hypothesis, which is, essentially says that the common factor underlying most environmental risk factors for psychosis are those that are somehow marginalizing or defeating. And we tried to see if this would replicate in the US, and did find that what you'd consider socially defeating characteristics are related to higher prevalence of psychotic experiences. This is something we're writing up now, and it's been a really interesting topic because I think there's something that a lot of the studies from Northern Europe are missing, which is that they tend to treat these forms of marginalization and stress as very individual level experiences. And one thing we're working on is trying to make a case for reframing this around social power structures and highlighting how many of the most impactful risk factors are those that are in some way indicative of systematic and structural separation from the larger group or larger society. So things like, um, uh, in particular, racial discrimination. And then the big one I want to talk about next is police violence exposure, which is especially relevant here in the US. Maybe I'll just pause there for a second and just have a sip of water. And if there are any questions so far, um, let me know if there's anything that needs to be cleared up before we move on. Okay, in that case, I'll keep going. Um, so I was doing this work when I was starting out as a assistant professor. I was at University of Maryland in Baltimore. And if you've been to the University of Maryland, you know it's basically right about as center in downtown as you could get, which puts it very near the West Baltimore area, where Freddie Gray was killed and where all of the protests around that were largely centered. And already doing work on discrimination in mental health, social risk factors in mental health. I had long, for about as long as I've been doing this work, I've thought about police community interactions. But it wasn't really until there were literally protests outside my office window that I started to really try to look at this as a specific research topic. And I think part of that was because it was hard to get data on this in particular, and there's so little prevalence data on police violence in the US that it was hard to make a case that this was something that should be researched. And that might sound ridiculous now in 2024, but if you look at this figure I put together, this is the number of publications, if you look at police violence and health in PubMed from the year 2004 on. In 2004, there was an article in the American Journal of Public Health by Hannah Cooper, who's down at, she's at Emory, basically bringing light to this issue, saying that we need to consider this a meaningful public health issue. And then you see nothing, 2 studies. Not till about a decade later did there start to be a few studies on this. And if you follow this issue at all, you know that the US is, for one, unique among developed, economically advanced countries for having very high rates of police-involved homicides, and is also unusual in how bad it is at tracking this. So we basically leave it up to individual police departments to track police violence, or their preferred term is typically excessive force. They all use different definitions. There's no centralized way of kind of getting this information together. The FBI attempts to do that, but states have to opt into it, and only about 8 states have. And then our main source of data ends up being things like the Guardian newspaper crowdsourcing information about, that they get off the internet or that people report to them about incidents of police killings. And so not really the, gold standard of data collection. So I got interested in this, and I was able to get a very small grant through the University of Maryland, which I was really happy that they were willing to support this work, because it was really still quite controversial at that time to even really raise the question of, is this a thing that's happening? Are there racial disparities? Is this enough of a problem to consider it a public health issue? So 2015, at least in academic circles, it wasn't really widely recognized. So I was trying to look into, how common is this? How commonly is this happening? Is it related to health and mental health? And I'll focus especially on psychosis and suicide, but we looked broadly at depression, anxiety, other conditions. So the first study, this is also despite all of its limitations, a bit of a plug for using online panel surveys because we were able to collect a lot of data for a very low budget. I think this was about a $9,000 study. Collected data on 1,600 people in Baltimore, New York City, Philadelphia, and DC. I think the quality of these kind of surveys is going down and down as AI gets better and better, but in 2016 it was still believed to be pretty good. Certainly not perfect, but basically outsourced to Qualtrics to find participants in these within the city limits of these four cities with a distribution that match the demographics of those cities. So basically quota sampling, which is not ideal for a representative sample, but for our budget, it was what we were able to do. And considering the existing data, it was very hard to get funding and still hard to get funding for a bigger study of this question. There also weren't any measures of police violence. We certainly are, there are efforts to track police violence incidents that result in death. But there weren't really any existing self-report measures of what we might think of as lesser forms of violence like physical, sexual, psychological, and neglectful. So things that aren't fatal. So following Hannah Cooper's 2004 study, we used the World Health Organization domains of violence. Physical is self-explanatory, I think, physical with a weapon. Sexual violence could include things like strip searches in public places, which are quite common. Psychological would be things like threatening language or discriminatory language. And neglect is an interesting one because that basically means if you're in a position of power to stop violence and you don't act on that power. So roughly calling the police because there's a violent incident happening and they either take too long to respond or do not do anything to stop the incident when it happens. Sorry, I actually don't have the prevalence data, but in these slides, but found quite high rates of people self-reporting exposure to these different different types of police violence exposure. Yeah, and thank you for the point in the chat. It's very likely that the lack of good data on this is not accidental. Yeah, so we're making some attempt. So despite some of these limitations, yes, there's a lack of good data. This is a little bit better than what we had then. Hopefully we'll get better data at some point in the future. But we were really interested in what the associations were with mental health. I'm realizing I should have had a slide in between these. So there was a first study that was called Survey of Police Public Encounters, where we basically showed that if you said yes to these items, you were at greater risk of depression, anxiety, psychotic experiences, and suicidal behavior. With really pronounced associations for the two big clinical factors that are of interest for this talk. Huge effects for suicide attempts, and quite large effects for psychotic experiences. So we did a second study, again, using panel data, this time a smaller one, trying to adjust for everything we could possibly think to adjust for as possible confounding factors, and making some, causality is always a kind of thorny issue when you're talking about cross-sectional data, but trying to make some predictions about causal relationships. And so this is really based on what I don't know if this was the origin, but I think of it as like the Columbia public health approach to thinking about causality, where they have done a lot of studies where they come up with predictions for the data that would be more consistent with one causal explanation than another, and then seeing what the data look like, even if it's cross-sectional. So this is what we came up with. So this is hypothetical data right now. This is a conceptual, looking at different possible ways that these factors could be related. So one, either comparing those with versus without exposure to each form of violence are at no higher risk for mental health outcomes. One, there's another possibility that there's uniform risk, so that no matter what type of violence you're exposed to, you're at similarly higher risk for, say, depression or psychotic symptoms. And we decided that this would be most consistent with a symptoms to violence model. So an idea that the fact that you are perhaps behaving unusually in the community leads to greater police attention. It doesn't lead to any particular type of greater police attention, but just the fact that there's greater contact means that you're more likely to be exposed to everything. The other model would be going from violence to symptoms. So the idea that a exposure to police violence is traumatic, highly marginalizing because it's really a violent incident coming from what should be the source of protection from violence, and often including racial components to it. Our prediction there was that you'd see a greater effect for the more severe forms of violence. So physical with a weapon, sexual, lesser effects for things like psychological and neglectful, which, while important, are probably not going to be as impactful as an actual incident of violence with a weapon. Sorry. So what we were really looking for was whether the data would be more consistent with this model, this kind of uniform elevated risk of mental health outcomes for those reporting any type of violence, versus this kind of model where the risk is greatest for those reporting the most severe forms. And this is looking at 4 different outcomes. These are the actual data now. And what we found was that it seemed to be more consistent with kind of this traumagenic model where the more severe the exposure, the greater risk of mental health outcomes. And this is distress, ideation, attempts, and psychotic experiences. And they all seem to follow a similar pattern. This isn't the main focus of what I want to talk about tonight, but I do want to call attention to this. These effects for suicide attempts are huge. This really needs to be replicated with longitudinal data, but I don't know if this is like cigarettes and lung cancer size. I don't know of any other risk factors for suicidal behavior that are that large. And we've shown that now in a couple studies. This is something we really need to pay attention to as a clinical and public health issue. But for now, let's go back to this connection between psychosis and suicide attempts. So they both follow the same pattern. It seems like a lot of the social environmental risk factors are shared between these factors. This is really, I think, arguably you could consider police violence to be kind of the ultimate in the marginalizing, socially isolating, little option for recourse, high risk of fatality, high intensity types of social traumatic exposures. And we see that that is one factor that seems to be connecting these 2 outcomes. So I just want to cover this a little bit more because it led to some of our thinking about how to try to intervene with these type of risk factors that seem to connect psychosis and suicide. So there's a policy statement from APHA, the American Public Health Association, in 2018 that started to really highlight that this is a public health issue that we need to think about, that we need to start addressing it through policy changes, and importantly, that we really need to recognize that for non-fatal incidents and for fatal incidents for the surviving friends and family, this is likely has a huge population level mental health impact, as well as minimal research evidence on this question. Now, despite this, the state of the field around this time, this is an actual quote from a reviewer I got when I tried to get a methodologically better study of this funded, was we already know violence matters for health. Why study police violence in particular? And this was kind of the general sense, was that this still wasn't widely regarded as a topic worthy of academic study. I think we've shifted from that. I honestly still have a lot of trouble getting this work funded, so maybe we haven't come that far, but hopefully other people are having better luck. I don't know. There are more people doing the work now than when I started, and It's hard to say exactly what the issue is, but it does seem to be an area where there's still a lot of conceptual pushback. But we do have data now that suggests that this is a widespread issue that we really need to think about. But because we had this question, we set out to answer this question because we wanted to be able to cite something that says, yes, police violence in particular matters, maybe not more, but differently for health. This culminated in this review article that was published in Annual Review of Clinical Psychology a couple years ago. And we came up with a lot of reasons why this exposure might matter more. Most of these haven't been empirically tested, but it's kind of an interesting thing to start to think about because when you want to intervene with mental health by addressing the risk factors that lead to mental health difficulties, you really need to start to unpack why those connections exist. And it turns out that there's a lot of reasons. And I present this here just as one example and one example that we really, excuse me, dug deep on. But I think you could come up with some similar type of chart for any other social risk factor. So here we're saying that police violence is connected to mental health symptoms. We know that there's some common effects of violence that lead to mental health symptoms, that really any type of violence exposure could lead to mental health difficulties. All these blue boxes are things that might make police violence in particular more common, which is what we see over here. Things like the fact of qualified immunity, that there's little recourse for incidents of police violence, that there's this was just mentioned in the chat, the very fact that there isn't systematic data on this is something that might make break down a potential deterrent. The fact that no one's tracking it means it may be more likely to occur because there are less likely to be consequences. Over policing of Black communities, American legacy of racism, all these things might make exposure itself more likely. The impact might be greater than many other forms of violence. These aren't things that are necessarily unique to police violence, but they're features of it, that there's always, basically by definition, always a weapon present. It's situated within power inequities. There's this threat of incarceration. And there's also factors that could impede coping or recovery from police violence, like the fact that with trauma, a lot of times you try to avoid the source of the trauma in the future. And there isn't really a way to necessarily avoid all police in the US. There's a stigma of reporting these type of incidents. So all of these are really ways that this one particular exposure could lead to mental health symptoms. So I'm going to shift a little bit away from that as a particular exposure because we're going to speak more generally about interventions. But let's, so taking that as keeping an eye on the time, just realize I'm a little bit behind where I wanted to be at this point. So keeping in mind the idea that, all these social factors could provide potential points of intervention. All these factors that make a social factor impactful are also potential points of intervention. I'm gonna, I think, move ahead a little bit to the intervention work, but just want to call attention to, we really boiled this down. Deidre Anglin, who does really incredible work on psychosis risk, especially within the context of ethno-racial disparities. Really, you should read this paper. I'm in the middle. It's not a self-endorsement, it's an endorsement of Deidre Anglin's incredible work on this that I was happy to be able to help out with. Really great job summarizing why systemic racism matters for psychosis in the US. Okay, I'm gonna skip ahead a bit because this is basically more of the same. It's essentially, there's a lot of evidence that these social factors matter, that the ones that are more systemic, structural, matter a lot for psychosis and suicide risk. Okay, so I want to think a little bit about what we then do to try to address this issue. So I want to walk through, or maybe before that, could pause again. Any questions before we shift over and talk about intervention work? Okay, it's funny doing this on Zoom sometimes you don't really, it's hard to read the room, but hopefully everyone's still with me. Let's see, one. All right, looks like that was sharing a paper. So thanks for that. All right, I'm not seeing questions though, so I'm gonna jump ahead. Um, okay, so trying to think through how do we use all this epidemiological data to really make some kind of actual impact for people who are um, experiencing something on the spectrum of psychotic symptoms or early psychosis. And my first work on this was, I think, especially of interest to social workers. This was before focusing specifically on the suicide risk aspect. We were looking at how to reduce duration of untreated psychosis, which is a whole topic on itself, but basically the blanket term for the problem where it takes people about 2 years to get into treatment after the development of schizophrenia on average. And I'm just going to quickly introduce this study we did that was based on the idea that, well, if it's taking them to 2 years to get into psychiatric treatment, they're probably somewhere else before that. And social workers tend to be everywhere. So I think a kind of pride point of our profession is that we kind of have our hands in everything. And if they're seeking housing support, food, uh, food security issues, um, employment benefits, whatever it is, there's probably a social worker there. So in this first study, we basically set out, and this was almost feasible in Baltimore because almost all social workers in Baltimore went to the University of Maryland. We basically used the University of Maryland alumni list to set out to try to train all the social workers we could get access to on how to identify uh, psychotic symptoms and make referrals to the early intervention services in Maryland. So Maryland has really state-of-the-art early intervention services for schizophrenia. But really the problem that those services run into nationwide is that the enrollment's less than what you'd expect based on what we know about the incidence of schizophrenia. So in this first study, we really set out to train social workers in schools and community centers, really anywhere we could find them that were not already working in a mental health setting, to rapidly assess and make referrals to specialized services. And we found that this did have an impact. Because of some methods complications, we ended up not having a good estimate of duration of untreated psychosis, but what we were able to do is look at referral rate. And we found that that went up way, basically it just about doubled during the period of the study. So we found that the referrals coming in were, for one, much more frequent, and they were much more likely to be accurate. So it's much more likely that we were getting referrals for people who actually had psychosis and not some broader definition of mental health needs. Okay, so we're going to come back to that idea in a minute. What I really want to focus on for this is the idea of not just getting people into services for psychosis, but addressing, in particular, that very high risk of suicidal behavior among people in the early course of psychosis. So for this current study that we're doing now, we're trying to adapt youth-nominated support team interventions for those who are at clinical high risk for schizophrenia. And I'm going to talk a little bit more about what that intervention is, but basically we picked it because it's one that's very client-centered, that's based on building social networks, which is something that a lot of youth with emerging psychosis have difficulty with. And it is, to date, the only intervention shown to significantly reduce mortality among adolescents with suicide, at risk for suicide, which is a concerning statement to have to make, but we don't really have a lot of good evidence for things that actually reduce the risk of suicide. We could guess what might work, but again, this is clinically something we still have a lot of trouble with as a profession, or not just as a profession. Psychiatry, psychology also have the same issue. We just don't have a good sense of what interventions work. But this is one that has some promise. So we set out to try to adapt youth-nominated support teams for those who are at clinical high risk for schizophrenia. So this means they're receiving services, they're already in services for having emerging psychotic symptoms that are less than the diagnostic threshold for schizophrenia, typically along with some kind of functional difficulty. So what we're really thinking about here are high schoolers, kids in, going into college, early stage of adulthood, most often start hearing things, start having beliefs that those around them find unusual and are distressed by it, a higher severity level than those who are just saying yes to psychotic experiences, items, and surveys, but not quite at the schizophrenia level. So we set out to work with clinicians and clients to adapt youth-nominated support teams for this population. We're now trying to implement it in one clinic, and then we're going to wrap up with a small RCT that really tries to look at its effectiveness across several clinics and potential mechanisms of change. I'm going to come back to these data in a few slides, actually. So why youth-nominated support teams? I already said a few of the reasons. This is just some of the data that led to our decision to pick this, is that most of the studies that have some promise for reducing suicide risk based on meta-analysis, again, most have no treatment effects. We're bad at moving the needle on suicide risk. But the ones that seem to be most promising in systematic reviews have some components of family or non-familial social support. So basically building up one's social support network. And we know that this is already a problem for youth who are receiving early psychosis services. So something where there may be a lot of room for improvement or intervention. The original goal of the intervention was to build a well-informed adult support network for youth who have left the hospital after a suicide attempt. And it was intended as an adjunctive intervention, something that would be used on top of existing psychotherapy, medication, et cetera. And similarly, we're using it as an adjunctive intervention for youth who are already receiving clinical high-risk services. And in its original form, it was for kids and developing a network of adult support persons, although we've made some adjustments to that, which I'll go over. But the general idea is having support persons that are, serving as, caring adults so that they're there to have meaningful conversations, supportive contact with the youth. And in the incident that a new crisis arises, they could be a safe way for that youth to get reconnected with clinical services. They could, be in contact with the clinicians and provide a pathway that may be less stressful than, say, dialing 911 for that youth to reconnect with mental health support. So they generally are just expected, they're not expected to be clinicians, they're expected to be supportive adults that the youth trusts that will connect with the clinical team as needed. And in this model, the clinical providers, often social workers, basically serve to facilitate helping the youth nominate who the support persons are and to check in about once a week to make sure that things are going well and to check in with the support people to make sure things are that they feel adequately supported, answer any questions, and so forth. And the results from the original study, and this is general population adolescents, this is not youth with psychosis. In fact, I think I can't remember now, I think they probably excluded people with psychosis because that's kind of the norm in suicide intervention studies. Originally didn't find any effects or found very small effects at 12-month outcomes. There's been some criticism of this study where it feels like kind of, it is something of an after the fact analysis, but they went back and they followed up on all these kids 11 to 14 years later and found that the group that had youth nominated support teams that's the blue line, had a much lower rate of mortality than those who were in the treatment as usual group. And some criticism is that it may be far-fetched that the effects of this intervention would last 11 to 14 years later. But I think you could also make the point that this isn't just building specific social relationships. You're giving these adolescents tools to know how to reach out for help and alternative ways to connect with support. So I think it's feasible that it's a meaningful difference. It's, you know, think about this intervention with those criticisms in mind, but also keep in mind that this is to date the only intervention that showed this kind of curve. It's shown a meaningful difference for adolescents who've had suicide attempts in terms of their subsequent mortality. So it's at least a promising thing to go on. All right. So we're currently adapting this for youth, the clinical high-risk youth. To do that, we have worked with youth that are receiving these services, or clinicians and family members at several different clinics. I'm going to go through this a little bit quickly. I'm going to skip the demographics because